Well, good morning. This is Bruce Pyenson, and it's my pleasure to coordinate the next two panels. We have a terrific follow-up to this morning's presentations where Jim Mulshine and Catherine Schmidt and Mary Pasquinelli all talked about the potential for lung cancer screening and more broadly thoracic health to make a big difference for the population, for people at high risk and the general population. And we're going to follow that up with the population health focused on what it really would take to have thoracic health be featured in population health efforts. And this gets into numbers and quantitative issues in ways that are very different from the rest of the quantitative imaging workshop, which is heavily focused on issues of imaging and interpretation of data. It's nevertheless still big data. Population health is a cornerstone of the dramatically changing healthcare system, dramatically changing in the US and around the world as the focus has moved to outcomes and value instead of volume, partly to improve outcomes, but also to get better value for what's increasing expenditures in many countries. So without further ado, let me briefly introduce the panelists. We're going to start with Dr. Mary Barton, who spoke at last year's quantitative imaging workshop and has a really important, vitally important things to say about how measurement is and quality is driving healthcare and some of the success stories there. We're also going to have a colleague of mine, Corey Gusland, who's also an actuary, speak about how the accountable care organizations are making choices. And finally, we're going to have Spencer Caruccio speak about how the world's biggest health insurer, the Medicare program, makes decisions about innovation and what they're looking for. So the straw dog that we're presenting is how the advocates and organization advocates of lung cancer screening can take risk for the outcomes of lung cancer screening, what it would take for them to put their money where their mouth is. There's a lot of programs that do that on a broad population health basis, especially in the US, notably the accountable care organizations, Medicare Advantage programs, and various private insurers. So we have 3 pre-recorded presentations, and then we're going to open it up for comments and questions. So see you all in person in about a half an hour. Thank you very much.
Good morning, I'm Bruce Pyenson, and this is the first of 2 sessions today that I will be hosting. And they're both about population health and about how thoracic health fits in or doesn't yet fit in with population health efforts. QIW sessions are all about measurement, quantification, and the kind of quantification we're going to be talking about and our guests are going to be talking about is a bit different than what others are here, but it's all measurement. We're going to be talking about the key elements of on a grand scale across thousands, hundreds of thousands, millions of people, how the health of populations gets affected and changed. And as we've seen in recent years, there's a huge focus on public health and population health outcomes. This is taking the form of concerns over the overly high expenditures on healthcare and the unaffordability of healthcare, as well as the outcomes of healthcare, which in the US are certainly less and worse than most other countries. I will say most of this conversation is US-centric, although population health is the universal concept. We have three speakers this morning. I'd like to welcome back Mary Barton, who's from the National Committee on Quality Assurance, one of the most important, if not the most important organization for population health measurement in the United States. My colleague, Corey Gusslin, who's an actuary, and who will be speaking about accountable care organizations and the kinds of measurements and quantification and financial and modeling that goes on as accountable care organizations choose what to do or what to not do. And the last speaker this morning is Spencer Cariucci, who had been with the Center, the Medicare Innovation Center, overseeing new models of accountable care. And he's going to talk about how the Medicare program views these kinds of population health programs. Well, I've created a straw dog to center these conversations. And the straw dog starts with the concept that implementing widespread lung cancer screening will have large health benefits for the at-risk population, smokers and ex-smokers. And so those benefits include identifying lung cancer at a curable stage, as well as diagnosing COPD and cardiac conditions earlier, and other benefits. And the question is, will provider organizations or communities be willing to take risk for successfully implementing these programs on a grand scale in their populations? In other words, would they put their money where their mouth is? So that's the straw dog. What does taking risk for lung cancer screening outcomes mean? Well, here's a few things it means. It means reaching a target for the percentage of people that that get screened. Today, it's around 5 or 6%. It's terribly low, as we all know. Another goal is reaching a target for an outcomes metric, such as the portion of incident lung cancers that are screen detected, as opposed to symptomatically or incidentally detected. Another outcome is reducing the spending on lung cancer treatment for a defined population. For example, the state of Delaware. Another outcome is reporting the results on what led to success or failure. And finally, having an organization, perhaps a hospital-based or a physician-based organization or a governmental organization, taking risk for these outcomes, being accountable. Well, Medicare program has taken the lead in these programs. There's about 60 million beneficiaries, 60 million people in the United States covered by the federal Medicare program. Most are over 65, some are not. And population health in Medicare takes two forms. About 24 million of the 60 million people are covered by Medicare Advantage plans. These are private insurers that take risk for financial outcomes as well as quality outcomes for the 24 million beneficiaries that enroll. There's another 12 million people that are not in Medicare Advantage, but are enrolled in accountable care organizations. So if you add the 24 and the 12, that's most Medicare beneficiaries are in a form of accountable care and population health. Well, here's a brief history. This is a well-established program, if under a lot of change. The first programs, Pioneer, started in 2012. Next Generation ACOs started in 2016. And this year, direct contracting entities have expanded. So there's a lot of history here and a lot of well-established processes. And we'll be hearing this afternoon from a leader of one of the successful ACOs and how they do it. So what is a Medicare ACO? Well, it's an organization, and it's a group of providers that deliver care to fee-for-service beneficiaries. And if they meet certain criteria, they can generate a bonus payment, and that might be savings or quality outcomes or a combination of both. The beneficiaries are attributed to the ACO based on a plurality of visits to certain providers associated with the ACO, typically primary care, and members might not even know they're associated with the ACO. The bottom line of this slide is the ACO is accountable for managing the healthcare costs for their members and other outcomes. And that's measured. It's not hand waving. There's well-defined metrics for that. Well, why do these ACOs exist? The goal is to get better value for the money that Medicare spends, reducing the inefficiencies, having the providers focus on value instead of volume, and saving money for the beneficiaries, the providers, and the Medicare program as a whole. So the Innovation Center has been key in sponsoring innovative programs and pilot programs, and they have the authority to actually implement these without going back to Congress to implement them on a national scale. And what they typically need is defined populations. They can provide administrative support and typically do for these kind of innovations, set up again a loss sharing arrangement. They'll sometimes provide startup type funding, and they'll do the measurements. So back to the straw dog, does it make sense for advocates, including folks in this room, in this virtual room, to attempt a thoracic health pilot through CMMI, through the Innovation Center? And here's just a bit of context. There's perhaps, round terms, 10 million beneficiaries who ought to be getting lung cancer screening. Almost none of them get it today. If the cost of doing a scan is about $300, and by the way, the cost of the scan is far and away the biggest cost in a screening program. Then there's about $2.4 billion potential spending if we actually screened 80% of those 10 million. That's a really ambitious goal. Put that into context, Medicare spends about $800 million a year. So lung cancer screening, at least the biggest component of it, is about 0.3% of Medicare spending. Is this big enough for people to bother? People in this room think lung cancer screening, thoracic health is important. So clearly we need to put the numbers together to demonstrate what the value is. Well, back to our speakers. We'll connect afterwards, and Anita McLaughlin from GoTo Foundation will be getting your questions, and we'll be talking again in a few minutes. Thank you.
Thank you so very much for inviting me to speak with you all today. I'm looking forward to sharing a little bit about what NCQA is doing in terms of measuring quality at health plans and what the future looks like for measures, including digital measures. The HEDIS stands for the Healthcare Effectiveness Data and Information Set. This is a set that is used by more than 90% of America's health plans. We are able to compare health plans across important dimensions of care and service, including preventive services, behavioral health services, coordination of care, and overuse and appropriateness. We have seen a very positive trend over the last 10 years. This is actually a 20-year view of the millions of members who are enrolled in health plans that report HEDIS data that is audited by the health plan. We saw in the year 2000 that there were 50 million members enrolled in these plans. Now, nearly 200 million people enrolled in health plans that report HEDIS data. The most recent year of the HEDIS data set includes 92 measures across 6 domains. It includes utilization and risk-adjusted utilization, health plan descriptive information, effectiveness of care, and these measures are used very widely in programs, including CMS's ACO programs, CMS's quality rating system, which measures the marketplace plans, the Medicaid adult and child core set. So HEDIS measures are widely used to hold entities accountable, whether they're Medicaid plans or commercial plans or Medicare health plans. When we develop measures, we are looking at several pieces of the pie. Measures have to be relevant and meaningful to patients and providers. They should address issues that are important to improving health. There should be substantial variation in the performance. Otherwise, it's not a useful measure to distinguish performance. And it should be within the control of the clinician or the clinical team to do something about it. So that's relevance. The second characteristic is scientific soundness. We take pride in basing all of our measures on the best evidence. And that is really crucial to the buy-in of health plans and clinicians both, in terms of understanding that these are measures that are measuring what's good for their patients. Measures also need to be accurate and reliable and valid. So we have to be able to get good data into the measure and a reliable result out. Finally, feasibility is really where the rubber hits the road, because the measure needs to be specified so precisely that everyone does it the same. And that's the only way to compare apples to apples. We need to make sure that when we create a measure that the needed data to complete it are available and universally available. The cost of data collection is sometimes an issue. We need to make sure that that's reasonable. And finally, the measures need to be auditable, because NCQA runs an audit of all our health plan measures. The data sources that are used, so we talked the slide before about data needs to be available. The data landscape is changing rapidly. And so what was created 30 years ago when HEDIS was created was a system where either a measure was administrative, so it used enrollment data or claims data, or it was hybrid, which meant that there was a chart review component to it. There would have to be a sample and chart review. And then finally, surveys. So you're probably all familiar with CAP survey, the Medicare Health Outcomes Survey. What we've done in the last 5 years is to create a new kind of measure that is looking at electronic clinical data systems. So a measure that uses multiple kinds of electronic data that can all flow into the measure. And by all kinds of clinical data systems, I'm referring to electronic health records, registries, case management systems, as well as claims, which are, of course, an electronic source of data. If you would like to learn more about our electronic clinical data system measures work, there's a website here. You can go and look. Easy to remember, ncqa.org/ECDS. Now, we are careful to explain to folks who may be new to measurement that not all good ideas can make good measures. If there's a clinical shortfall, usually it's because science is changing rapidly and the measure, is outdated by the time it's created, or there may be a need for risk adjustment and none that's available. There are technical problems that can happen, like if everybody that you're going to measure has a very tiny number of patients to whom this measure would apply, then you're not going to be able to use a measure like that to compare clinicians or to compare health systems or to compare health plans. And then external issues are really about understandability. So can users understand the results? Can accountable entities control or influence the outcome? And in particular, where there are differences in delivery systems or regional differences across the United States, sometimes that is troublesome to our approach, because we want to make sure that we're making a fair comparison all across the country. So the HEDIS measure development process follows a pretty standard set of steps. We have ideas, we select from among them, we develop a measure, it goes to public comment. We have something called first year evaluation, which is the first year a measure is in use. It is not publicly reported, but we take in the data and we review it to make sure that the measure is performing as we thought it should. And if that is all, if everything looks good, then it can be voted to be publicly reported the next year. And then we do ongoing evaluation of our measures. And ultimately, our hope is that measures will so-called top out. So everybody will be doing the thing that we're asking them to do all the time, and then we can retire the measure. So NCQA is really committed to quality measurement using objective measures and in particular, providing an impartial third-party evaluation and audit. We have quality programs, including physician recognition programs. So there's a diabetes recognition program, and we release our measures in Quality Compass, which is viewable on NCQA's website. I'm going to now pause and talk a little bit about a colorectal cancer screening measure, because I understand that you are all interested in cancer screening and that there are, potential areas in particular that you're interested in looking at. And the story of the colorectal cancer screening measure is about the story of concerted incentives, because we have this measure that the current measure looks at adults aged 50 to 75, although we're working on adjusting the measure. The U.S. Preventive Services Task Force lowered the age of starting colorectal cancer screening to 45, and so we're working to update our measure to use that time frame. And it looks for people who have had one of these cancer screening tests in the last year, 5 years, or 10 years. And there are some exclusions to the measure: folks who are frail or who have advanced illness or who have already had colorectal cancer, and therefore screening is not really appropriate for them. So the data that I'm going to show you shows us that the commercial health plans are not moving very quickly, but Medicare plans are. So this is the average national performance on the colorectal cancer screening measure from 2010 to 2018. And you can see that Medicare in red started lower than commercial, but has risen way up to 72%, while commercial has increased a little bit over that time from 56 to 62%. Next, I'm going to show you some box and whisker plots. These are a way to present data that shows the maximum, the minimum, the interquartile range, 25th to 75th percentile, and then the median in the middle there, that line, and the X is the mean. So commercial health plans, and this is looking from 2014 to 2018, the 5 years, really consistent performance of around 60 to 62% of the mean of their patients are getting colorectal cancer screening. And the number of commercial health plans that have surpassed the Colorectal Cancer Roundtable's goal of 80% being screened is only 10. And if you could sort of rethink about this and understand that Medicare health plans are graded by CMS in the STARS program, and getting a high mark or 4.5 stars or 5 stars is really beneficial financially to the health plan, because they get bonuses and they get other benefits that really make it a high value exercise to try and improve all of the measures that are in the CMS STARS program. And colorectal cancer screening is one of them. So since 2014, we see this steady move up in the mean, and the 75th percentile, which was at about 72, is now at 80. So the health plans are really moving their efforts on improving colorectal cancer screening in the Medicare population. The number of Medicare plans that have over 80% screened, look at this, from 25 in 2014 to 105 in 2018. So that is really the story of what a measure can do when it is joined with an incentive program like CMS's STARS program. You can really put together a clear case to health plans or other responsible entities as to why they should improve. And so that is what I wanted to tell you about today. I appreciate the time, and I look forward to the discussion at the end. Thank you.
I am Corey Gusslin, Principal and Consulting Actuary with Milliman. I primarily work with provider organizations, accountable care organizations, basically provider entities taking on risk. My area of expertise is value-based payment models. And the topic of this 10 minutes is accountable care organizations, perspectives and incentives. So Bruce Pyenson asked me to talk about how do ACOs think about their risk options. I'm going to try to answer that question, but also connect it to the broader workshop question, which is, would ACOs be willing to take on risk for a pilot program, such as centered around population health interventions or healthcare screenings? So the way we're going to walk through the talk today is talk about Medicare ACO basics. Bruce has already touched on those a bit. Then get into the economics and incentive structures with those, and wrap up with exploring some of the questions around incentive structures. Do those encourage investment, and in things such as population health interventions and cancer screenings? So let's talk about Medicare ACO basics. So Bruce already covered this a little bit and talked about what an accountable care organization is. I just want to emphasize a few things in terms of ACO basics. First of all, what an ACO is. There's a lot of variation, and the incentive structure and economics is going to vary based on that organization characteristic. For example, if it's primarily just made up of physicians, or whether or not there's a hospitals and health systems affiliated with it, or maybe there's even an outside entity like an ACO aggregator, that will vary and change the incentive and economic structure. So something to keep in mind there. In terms of what population an accountable care organization is accountable for, it's typically a broad population based on which patients the doctors that make up their ACO are seeing. But I do want to note that this oftentimes does include cancer patients. So very much today's discussion is relevant to ACOs. And then in terms of what services are they accountable for, it is Part A and B services, not Part D for Medicare ACO programs. For non-Medicare ACO programs, they're like Medicare Advantage or commercial, sometimes retail drugs or Part D expenses are included. But it is very important to know that Part D is not included, particularly when you're talking about accountability with things like cancer care. So how does CMS define value in Medicare ACO programs? And value is often defined based on measurement against the financial benchmark. The financial benchmark is comprised of really two components. One, it's the historical baseline expenditures for an ACO, and the other is it's the regional performance that an ACO provides services in. So that, got this somewhat simplified representation of the formula although it's still somewhat complex. But the key thing to note is there's multiple years of experience in expenditures that goes into setting what a accountable care organization's target is. And then that historical experience is oftentimes compared to regional expenditures to make an adjustment based on ACO regional efficiency. What this boils down to is that ACOs are basically competing against themselves to a certain extent, and also competing against their region. And so the economics and incentive structure is largely driven off of that. There's a lot of implications. The second point I want to make is that a key component of any financial benchmark methodology is that baseline or benchmark period used to set the target, does that move over time? And in Medicare Shared Savings Program, it is fixed for the agreement period, which is right now 5 years in length. So there is an opportunity, if interventions drive value, that some of that value could be captured and realized by the entity driving that value over a multi-year period. That's not always the case in other ACO programs outside of Medicare, but it's something to keep in mind because it has implications, maybe something we can discuss later on. So what does the incentive structure look like for Medicare ACOs? What are the program and risk options that they have to choose from? The two main programs that they've typically had an option of is to join CMS's flagship program, Medicare Shared Savings Program, where a majority of ACOs reside. And then there are pilot programs that are testing new ways to deliver care and pay for care that come out of CMMI. Within these programs, within each of these programs, so right now, what we've got here in blue, we've got Medicare Shared Savings Program, and then in green, we have direct contracting, the direct contracting program. These are the options that ACOs are deciding on for years 2022 and beyond. If you think about what are the risk options within those programs, we've got those highlighted in this table on the shared savings rate, and then and then we've got shared loss rate in the second row from the bottom. And you can see that if they are to be able to beat their financial benchmark, they could share in anywhere between 40 all the way up to 100%, depending on which program and risk track they select. Shared loss rate, in some instances, if they have a limited time period to be an upside only, where they don't have any downside exposure. But after that, they're going to be exposed anywhere from 30 to 100% of risk. So there's meaningful incentives with these programs. And so going back to that central question, which is how do they select amongst all these competing program and risk options? Typically, when we're working with them, they're bringing us to help them figure out which program do they have the greatest likelihood of success in, and which program are they going to have the most upside without exposing themselves to downside risk beyond what their risk tolerance is. So that's oftentimes how we work with them, and hopefully gives you a better understanding of some of the economics in play. So to wrap up, we want to go through a few questions here that are relevant to the broader agenda with the workshop. The biggest one being, does an ACO incentive structure encourage investment in population health interventions? And then I'm going to go through each one of these questions that Bruce provided for me in the agenda. So how does an ACO think about population health interventions such as screening? Is it prominent? Is it on their radar screen? I would say, for the most part, no, I don't see it very high on the list. The two things that come to mind that they're oftentimes thinking about is the quality metrics. Sometimes those do include screening, but those that CMS or any other payer that they're contracting with give them, but also they're focused on total cost of care reductions. However, there are lots of opportunities to reduce expenditures. And because of that, they're oftentimes doing some type of analysis or review to prioritize and have a few areas of focus. Those areas of focus, I'm most typically hearing things like post-acute care management, avoidance of ED utilization, site of service shift. Those are the things that come to mind. I don't hear things like thoracic screening oftentimes prioritized within that list. There's lots of competing priorities, and they oftentimes seem to focus on just a handful of things, and that doesn't seem high up on the radar, at least what I'm hearing at this moment. Next question, which is, would an organization be willing to take on risk for such a demonstration or program? I'd answer this two ways. Firstly, within the ACO program construct, and then second, as maybe a pilot that's run outside of this. Within the ACO program, I do think the incentives are there, as we've showed you earlier today. If the cost of putting these in and paying for these, and within a few year period could be realized through offset expenditures, I think there is potentially a case to be made there. There is an element of whether or not, when they avoid these costs associated with it, how that has implications on the financial benchmark. And it gets a little bit complicated, but I think there is a compelling business case there. And that one challenge, though, would be the population that they would potentially, even within a large ACO, what percentage of the population this would impact. And it go back to the response to question one, it might not be high enough up on their radar versus other competing priorities. But I think there is maybe some hope there. If thinking about a pilot like what Bruce has put at the straw dog example, and is this something that could be considered there? I think there might be some openness. I think they'd probably bias. I'd bias towards thinking that integrated delivery systems and multi-specialty groups would be with that focus on providing care for oncology and cancer actively, patients with active treatment of cancer would probably be more biased towards participating in this. But I have seen a lot of uptake from those groups in programs like bundled payment programs and oncology care models. So I think there could be some interest. Third and final question, do ACOs ever think about trying to get CMS funding for their own design that doesn't fit into one of these standards? I'd say this seems a little bit more focused and more specific than what I'm used to them pushing and advocating for with CMS, at least the ACO groups that I work with. However, this seems like more of something that I'd expect to come out of the physician-focused model, technical advisory committee, PTAC, that they've had a lot of great proposals, as many of you might know. I don't think any of those have actually been acted on by CMS or CMMI, but it seems like something that would come out of more of that group. But it's just a little bit more focused than what I'm used to. I'm used to them talking about more broader program changes and or more just technical tweaks to the existing ACO program, which isn't nearly as focused as what we're talking about today. So hopefully this gives you some additional background, gives you some ideas about how ACOs think about their risk options, and look forward to discussing with you. Thank you so much.
Everyone, my name is Spencer Cruciu. I'm a vice president at the Oxyon Venture Studio. Formerly, I was a senior advisor at the Center for Medicare and Medicaid Innovation. Before that, was head of data analytics at City Block Health and vice president of product at Remedy Partners. Today, I'm going to talk through a little bit of a framework for how the Center for Medicare and Medicaid Innovation thinks about bringing value-based payments to different populations and different models. Talk through a little bit of a mental model that I've used as thinking through the different features of different models and how, when it comes to building a new model or applying a new payment flexibility or a new waiver, it fits into the broader universe of CMMI models. So just level setting, the Innovation Center is really focused on three major goals, and that is to improve patient care, lower costs, and better align payment systems to promote patient-centered practices. More recently, the Innovation Center has released a strategic framework for how to think about achieving these goals. And this kind of strategic framework starts at the top with building a health system that achieves equitable outcomes through quality, affordable care, and person-centered care, and then uses these kind of tools or strategies beneath to achieve these goals. So that's driving accountable care, advancing health equity, supporting innovation, addressing affordability, and partnering to achieve transformation. All of these strategies will filter down into various ways in which models will actually be created or implemented. What has gone on in the kind of the past few years of CMMI is a lot of reflection and thinking back towards over the past 10 years of CMMI, what lessons have been learned about why models were successful or why models haven't maybe achieved the goals that we've set out to see them have. So I'm going to talk through some of these because I think they relate in a lot of detail for how do we think models will be implemented going forward, and for any new intervention or new kind of payment system or new population, how might the Innovation Center think about implementing a new model? So first, they acknowledge that health equity needs to be embedded in each model. Historically, we have seen kind of inequitable rollout of models that they focus in certain areas, not others, or haven't really kind of built with equity as in the forefront. The next, to streamline the model portfolio and reduce complexity. Overlap is a very technical problem within models and actually gets very complicated when looking at the impact that model has. If there are multiple models operating in an area, it's both confusing for providers that are looking to operate on them. But when it comes to actually trying to understand the impact of those models, it can make the calculations very complex. And therefore, the learning that we hope to gather out of these systems can never really come to fruition. The third one is that there really have been tools to support transformation. So a lot of these models require providers to expand their scope of practice, to be able to start taking on risk and doing the activities that can help manage that risk. And in doing so, providers need to implement new technology systems or understand data analytics and the ability to hotspot certain patient populations. And that can be a burden for a lot of smaller independent providers. So CMMI has acknowledged that the ability to provide data, the ability to provide other tools and services that can help providers participate in models is a really important part of thinking through either implementing a new model or transforming models. Next, complexity of financial benchmarks have undermined model effectiveness. These models are inherently very complicated. Either a benchmarking approach or risk adjustment or payment flexibilities are inherently very complicated things. And for providers to understand what they are being held responsible for, how they need to act within them so that they can clearly focus on patient care is a burden. So CMMI is acknowledging that as we think about model development going forward, these things need to be built in a way that is not complex on the participants, both participants being beneficiaries and or providers, but that complexity needs to be done in a way that enables everyone to clearly understand what the incentives are. Again, models should encourage a lasting delivery transformation. While ultimately CMMI models are tests, right? They are testing payment flexibilities. They're testing to see what we might want to implement in broader Medicare when it comes to paying for healthcare. We would want models to encourage long-term lasting transformation within the healthcare system. If it is a thing that lasts for 2 years and once the model ends and there's no more impact, that is not the ultimate end goal of these things. They should all be building on each other to really create the health system of the future that we all want. And next, design of models should enable broader participation. I think this has been a bit of a challenge relating to some of the other points on this slide of both the burden of different tools and services, the complexity of financial benchmarks and models that has not enabled all providers to be able to access and join these models. That has led to kind of decreased participation as well as potentially decreased results. So I think the combination of a lot of these factors enable broader participation, both on the different populations that these models can affect, as well as the different providers that can participate. So as we think about a model or implementing a new model, there are kind of three major questions that I tend to think about. And this relates a little bit more of like a tactical version of the strategies, more focused on kind of the model implementation and design. But it's really three things. So for a given model, which is a big deal to produce and requires a lot of design, a lot of implementation, a lot of kind of provider burden if they're taking these on, it kind of three questions. And is it scalable? Meaning, do we think this is something that is generalizable? meaning you can both scale like nationally, that the tools and services are there, that providers are ready to do this type of model, that we can clearly see how this can be something that becomes part of Medicare fee-for-service. And then tied to that is a generalizable, right? If we implement it in one MSA in New York, does that mean it can implement to a MSA in Texas, right? Do we understand what the specific aspects of the model that make it unique to a specific community or not? And how do we believe that they can then generalize across different communities, and ensuring that this model isn't just going to, succeed in one area and not be able to succeed in others? And then the last one, obviously, does improve quality and lower cost. We want to ensure that for all models that we have the clear kind of use case that we can say that this model has a clear theory of change and achieving these more equitable goals. And this ties to the just general wanting to drive broader transformation. Next, kind of taking down a level below. As we think about trying to achieve these goals, both the strategies set by the new strategic direction of CMI, the kind of key, more operational questions that we just talked through on this slide, there are tactically a few set of levers that CMI can actually use to incentivize change or to create a model. These are funding, right? The ability to give providers or other organizations money to implement different interventions or different models. It's capitation, right? It's giving them money in advance on a more regular basis in exchange for fee-for-service dollars. It is giving providers risk, right? That can be shared savings, that can be global risk, but in some way tying a portion of a provider's money to some sort of risk, some sort of kind of other outcome. And then payment flexibilities, right? Which is, can they change how fee-for-service is paid today? So it's still maybe a fee-for-service mechanism, but it is waiving the homebound requirement for home health within a particular waiver, enabling the fee-for-service benefit that exists today, but more flexibility in how it's paid. And ultimately, models are a lot of combinations of these factors laid on kind of a foundation of attribution and benchmarking. So as we think about models, or think about should something be a model or should it be a feature of a model, a lot of it kind of comes down to these factors, right? What is the thing that we are trying to enable or trying to incentivize that we think will drive savings, right? Is that just a flexibility? Is that, oh, we want to pay for this new thing, but we want to pay for it in a fee-for-service way, which we think will have downstream outcomes and drive down savings, but ultimately it's one flexibility. Then maybe it should be something that's part of another model, right? That's a feature of another model. Or is this fundamentally, we want to create a new risk construct and we want to, change the way in which we think about doing a new episode. And that new episode is a new risk construct. Then that may be a new model. But if the risk construct that you want to do is total cost of care risk based on the PCP, maybe this should be something that's a flexibility as part of MSSP. Capitation is similar. Capitation itself can be a feature of other models, right? Capitation is the testing to see if cash flow or just general incentives changes can drive different improvements or resource allocation. That can be nested as part of a full risk model. That can be part of a more episodic model of testing capitation. And then funding is really a feature again as well of saying, okay, for this given provider set of which this model is designed for, we think that there is actually a large amount of startup costs, that it costs a lot for a provider to implement a new system. And funding can help kind of incentivize or bring providers into the model by giving them some startup costs. So all of these are a lot of different features that can be layered on what is maybe a core chassis of, say, a total cost of care, more primary care focused longitudinal model, or an episodic model, more focused on an individual kind of time period and or condition. And then there's a lot of ways that these can be mixed and matched. And I think historically, when we've looked at the model portfolio of CMMI, what has happened is that the mixing and matching of these we've just created a bunch of new models. And I think the new administration has recognized that can lead to a lot of complexity. So there are other ways to create bigger models and then use these features as ways to innovate. So I think as it comes to different conditions or different interventions that we would want to see kind of brought into a value-based construct, I think the key question comes, is this a feature that should be implemented on top of another model? Or is this a new model in its own right? And I think it comes down to these key questions of, is it fundamentally changing attribution and benchmarking and risk structure? Or are we looking to add a flexibility or looking to add, a capitation or a funding mechanism that can then be a kind of a feature within another model? So summarizing a little bit from the prior of when to think about something as a new model versus when to think about something as an existing model. When we're looking at kind of building a new model, that requires implementing kind of all of the things in model design, right? That is benchmarking. How are you going to measure someone against the benchmark to determine success? How do you do attribution? How are providers signing up for this model? How are patients attributed to those providers? How does that all work? Risk adjustment, right? How is the risk adjustment working to ensure that when it comes to the benchmark, that those benchmarks are accurately representing the risk attributed to the population, which is then attributed to measuring the provider? And then lastly, how are these combined into how do we evaluate the efficacy of this program, both on a quality and cost basis? Right? If we, as we think about implementing or building a new value-based care model for a given intervention, if it is going to have to change these fundamental things because of its design or because of what you're trying to incentivize, that is when to think about a new model. But I think in instances of how we think about keeping the CMMI portfolio tighter, we'll want to kind of drive less of these and more think about how can we use existing models, say existing MSSP, right? MSSP has a benchmarking approach, it has an attribution approach, it has risk adjustment, it has built-in evaluations that have been going on for a while. How can we maybe implement kind of on top of the existing model new features or new flexibilities that can kind of micro test different interventions that we might want to implement? So this can be done in all the ways that we talked through before, right? If we want to intervent new flexibility on paying for some sort of intervention, we can put a benefit waiver inside of a model to enable providers to start to implement that intervention. If they believe there's an ROI both on cost savings and improved quality. And then CMMI is able to, in that model, do an evaluation to test, okay, for the ones that have used this waiver versus not, what do we see as the impact, right? But it enables a more micro test without doing fundamental new builds of models, leading to all the complexities that we've seen over the past 10 years. It can be the same with funding, right? Okay, we want to incentivize a new provider group, right? We want to enable more rural providers to enter this model. But we have found that rural providers do not have the budgets to go out and buy IT systems. How can we think about giving an advanced funding for them signing up for MSSP so that they can enter these models, right? It isn't changing anything about MSSP. MSSP is still the same model, but AIM is then allowing more money to be given to these providers so that they can enter. Right? So it's just a feature change, not an entire model change. And the last two, benefit enhancements and payment flexibilities. Similarly, right? We want to give more payment flexibilities. We want to enable capitation, right? We want to enable PCP to not be paid fee for service, but be paid monthly PMPMs for their expected fee for service payment. Right? We could do that within existing models. That can be a feature within existing models on top of a four-list framework or on top of another framework. So all of these, I think, have to exist in parallel. But as we think about implementing new value-based payment models going forward, thinking about these things as potential features within existing platforms, I think will be the right framework that will enable faster iteration, as well as more consistent evaluations, and hopefully greater uptake of value-based care models going forward.
Well, I want to thank our panelists, and we have a few questions, and in the old days, these questions would be standing between you and lunch. That doesn't mean the same in these days, but I think Spencer framed a really important issue of whether of creating new models of care or creating new features in existing models. And I would characterize the description of HEDIS and STAR metrics that Dr. Barton gave as belonging to the adding features to existing models, measuring Medicare Advantage plans or measuring ACOs or measuring others on lung cancer screening versus the straw dog that we created of creating a new program that would promote lung cancer screening, or perhaps the new program that promoted exercise as a treatment. So I wanted to ask the panelists to briefly comment on that dichotomy, of the value for lung cancer screening for thoracic health, of going in the direction of creating a add-on to existing programs versus starting a totally new program. Does anyone want to comment on that?
I would say, as a uninformed outsider, that it would be probably easier to add on to an existing program than to create a de novo new program. So if you're looking for something that's timely, that would be my focus.
Yeah, I would agree with that. And I think it kind of highlights a little bit of what Corey was saying as well, where, if you need to enable it, either you make it a quality measure or it's some waiver that can be adopted, it becomes on the providers and the programs that recognize the value, that are going to take it on operationally and are going to make sure that these things happen at the right time for the right patients in coordination with the right providers, can be a little of that like voluntary action of like, okay, we recognize the value of this. We thank, CMS for enabling us through some mechanism or, through quality bonus or measurement. We are going to take it on ourselves to really push this forward because we see the value. And I think that could be a great learning opportunity for the system overall, because it enables people who are recognizing the value to really implement and run with it. And then we can learn from that system of like, how can this scale then to be a more framework or mandatory type construct?
I just add, I think you could probably make a case for having it independent. You could make a case for having it consolidated. That seems to be the big question of the value-based payment policy world. And it seems like, regardless of what I think or others on this panel think, it seems like the movement is going towards less models. That seems to be the policy push. And I think there is a lot of opportunity for that. Spencer called out the challenges on how models interrelate with each other. Healthcare is not always that easy to like define who should be accountable for which patients or which services. There's a lot of overlap. And I think that's just the reality that we all have to deal with on payment model design. But it seems like things are moving towards consolidation, and therefore maybe building it on a chassis is, that's already working, at least one of the more stable, comprehensive ones, would maybe make more sense with the way things are moving.
Thank you very much for that. Another question for Dr. Barton. The really impressive graphics that you showed about colorectal cancer screening, I was looking at that, and from a reimbursement standpoint, I know that Medicare fees are much, much lower than commercial fees, especially for the anesthesia component, which is an important component of colonoscopies, and for gastroenterology as well. So it seemed that, I've annoyed people in this group by saying, no, don't demand higher reimbursement. That's not the issue. And it seemed as though, assuming that Medicare Advantage kind of pays what Medicare fee for service pays, which is probably mostly true, it seemed as though it wasn't the money being paid to the providers that made that difference.
I think
your thoughts?
you put your finger on it. It's not the money being paid to providers that makes a difference. So, health plans are being measured on this, and that's publicly reported data about their performance. So they're being compared to their peers. So that's a powerful motivator. The things that a health plan can do to facilitate colorectal cancer screening are, first of all, colonoscopy is not the chief method of colorectal cancer screening, right? So if you belong to Kaiser Permanente, they mail out fit cards. And so patients do that at home and mail in the cards. So I guess so my answer is that colorectal cancer screening is mostly not colonoscopy, that health plans have a number of levers they can pull to increase colorectal cancer screening, including they could widen their network of colonoscopists, right? Just to pick one possible thing that they could do that, whether or not they pay them a lot or a little, it's still work for the colonoscopist. And I'm sure that the folks, gastroenterologists who I know would prefer to screen people who need screening. And so people over 65 are definitely in that position. And if that's paid for by Medicare, it's paid for by Medicare. So thank you for the opportunity to answer that.
Well, thank you very much. I think we have time for one more question, but before our last question, I want to remind folks to fill out the questionnaire. Jim Mulshine, who's sitting right next to me, managed to elbow me without getting on the video, but please fill out the questionnaire. Anita, do we have one?
We have one audience question, and I'll read it out loud. Can autonomous reading of radiologic images be considered as a trend for new model of lung cancer screening?
Does anyone want to take that on? I think that overlaps a couple of issues. So, if there's a CPT code for autonomous reading of a scan, that would flow into the evaluation of a HEDIS metric, of an existing HEDIS metric, I suppose. Mary?
Well, I think that the point I would want to make is that if you use AI reading, you still need to get people into the scans. So to my understanding, the point that is making the performance so low is not, hard to find readers. It's that you're not getting people into the scans. So I think that could be an innovation, but it would not solve the current situation.
Spencer, Corey?
That makes sense.
Nothing to add.
Well, I want to thank the audience for listening to us, and especially thank the panelists for the excellent presentations you gave. And we'll reconnect at 1:15. We have a couple of terrific panelists, and we've got Dr. Jaffrey, who's runs an ACO at the University of Wisconsin. And we've got Dr. Paul Lindberg, who's Chief Medical Officer for Screening at Exact Sciences, which is developing, one of the companies developing a multi-cancer early detection blood test. So I'll see you all after lunch. Thank you. Good afternoon. Welcome back to the afternoon session of Quantitative Imaging Workshop number 18. And this is Bruce Pyenson. For those of you who were in the morning session, we had a terrific morning presentations on physical exercise and the overview of the conference by Jim Mulshine. This is the second afternoon session, the second session of the topic, what is needed for thoracic health to fit into population health? This morning, we talked about measurement and population health models of the future, and going through issues such as HEDIS metrics and alternative payment models, accountable care organizations. And this afternoon, we're going to talk about technologies, new and existing, with focus on lung cancer screening and thoracic imaging and early detection of cancer, and how they fit into population health, or perhaps how they don't fit into population health. We have two terrific panelists. We've got Jonathan Jaffrey, who runs the accountable care organization associated with the University of Wisconsin. It's one of the more successful ACOs, and he's going to talk about some of the successes and the processes they've gone through. And then Dr. Paul Limburg, who is the Chief Medical Officer for Exact Sciences Screening on early detection. And they're one of the companies that is developing multi-cancer early detection. And then we'll have question and answers. Please feel free to send your Q&As through the Q&A. For participants and panelists, you don't get to submit Q&A through the Q&A, but you can send your questions to Anita McLaughlin through who's the coordinator with me through the chat. So I'm going to start with a few background pieces on setting the context for population health, and asking some questions about how the material that we're going to occupy ourselves with in this conference fits into that. So let's see. So I've talked about this slide, and we created a straw dog for purposes of focusing the conversation on, many of us are disappointed with the very low take-up of lung cancer screening, estimated at about 6% of those who need it, and recognize the enormous benefits of that. And benefits are probably bigger than and extend beyond lung cancer to other cardiothoracic conditions and even other conditions. But what will it take to get provider organizations, communities, payers to take risk for the success of programs? And in the context of this afternoon, we're going to think about that with both the existing and the new technologies. So how can thoracic health and cancer downstaging appeal to population health organizations? As we know, the healthcare system in the US and around the world is moving from volume to value. It's especially noticeable in the US, where we spend way more than any other country on healthcare, and our outcomes are worse than most, or perhaps all, of the other advanced countries and many other countries in the world. So our system is currently volume-based. The more providers do, the more they get paid, and the future we hope will be one where they get paid more for producing better outcomes. That's the concept behind accountable care organizations. So Dr. Jaffrey will talk about his success stories, perhaps some other stories, and we'll hear from Dr. Limburg. And the discussion is going to be whether ACOs, Medicare Advantage, Medicare fee-for-service, commercial insurance are likely to champion lung cancer screening or the multi-cancer early detection or something else. The payers who are perhaps among the most influential organizations in healthcare, have a lot of priorities. And what would it take to make lung cancer screening, early detection one of those priorities? And which direction might they go? So bear with me while I adjust my screen a little bit. Oops. A little bit of background on where we are in the US and focus on the Medicare population. That's where most lung cancer deaths happen. That's where most screening should happen for lung cancer. There's about 60 million lives in Medicare in 2021. That makes Medicare, by some measures, the world's largest health insurance company. Most people are over 65, but there's millions of people covered by Medicare who are under age 65 through disability or through the qualification with the end-stage renal disease program. Population health is probably most developed in the Medicare program. There's about 24 million lives in Medicare Advantage, which is private insurance. That's growing rapidly, and Medicare Advantage is expected to cover the majority of Medicare beneficiaries within 10 years. The rate they're growing sooner than that. Medicare Advantage are private insurance companies that get paid by the federal government to take over responsibility for all the Medicare benefits. And certainly a growing and influential force. And they have risk for outcomes by the nature of their contract with the federal government, and also by the nature of the rewards programs or penalty programs for outcomes through the STARS program, or the quality metrics that they get measured on. There's 36 million Medicare lives in fee-for-service. That's original Medicare, Parts A and B. 12 million of those are in accountable care organizations. Accountable care organizations are provider-based arrangements who have voluntarily agreed to take accountability, including financial risk, for the outcomes of populations of people, of beneficiaries who are attributed to them. So you add the 24 million and the 12 million, 36 million, that's most of the Medicare program has population health as its core in some form. And those are growing. There's certainly interest by advocates to have all of the fee-for-service lives move into some form of accountable care because of the benefits of population health and coordination. Well, as I had mentioned, the attempts to control cost and improve outcome really center around a couple of catchphrases: pay for value, not pay for volume. Other people may be familiar with the triple aim, that is to improve quality, reduce cost, and make everyone in the system happier, make it work better. The traditional system that most of the clinicians in watching today probably think about fee-for-service, where Medicare and commercial insurance pays an amount for every service they do, and hospitals get paid that way, and doctors and pharmaceutical companies, skilled nursing facilities, and so forth. So the traditional approach is volume. Population health program has a number of alternatives to it, including value-based programs. Some examples of that are shared savings. That is, there's a budget set, or benchmark is set, and if the spending for a defined population falls below that threshold, some of that savings gets shared with the risk taker. That might be a Medicare Advantage plan, it might be an accountable care organization, or something else. There's also quality outcomes that come with money. We heard this morning about the success of colorectal cancer screening, which is a quality metric that shows up in HEDIS metrics. Well, it turns out Medicare Advantage plans have a very direct financial incentive to promote colorectal cancer screening, much more direct than commercial insurers. And not surprisingly, Medicare Advantage plans have seen a much faster growth in colorectal cancer screening than commercial insurers. So that kind of revenue incentive for the payer seems to work very importantly and successfully. Well, I want to provide some context, and then we'll go on to our panelists. But let's talk about current lung cancer screening process as a tiny piece of Medicare spending. We think it's a very important potential, but let's suppose there's about 10 million Medicare beneficiaries that should be screened. That's a round number. Maybe it's a little higher, maybe it's a little lower. It's probably within 1 or 2 million of the right number. But let's start with about 10 million. And if the annual screen costs about $300 per screen, we can calculate what the annual spending is for lung cancer screening. By the way, the screen itself is by far the biggest expense item in a screening program. The follow-up from screening is actually pretty rare. Doesn't happen very much. So the follow-up diagnostics and monitoring really don't add very much. The big cost item is that $300. And if you do the math, 10 million times $300 per year, and suppose 80% of the people are screened, that's about $2.4 billion in spending. Medicare itself spends about $800 billion. Well, Medicare spending plus the cost sharing that might be picked up by Medigap or patients out of pocket or Medicaid. So lung cancer screening, if we had a fabulously successful program and we're screening something like 8 million people a year, would add far less than 1% to Medicare spending in a year. So the screen itself isn't a big driver of finance or outcomes. So what would be the proposition for a thoracic health population health measure, and what would cause lung cancer screening to take off? You know, the low dose CT or the multi-cancer early detection, the blood tests. Here's a bit more of the perspective on for providing context. The bottom line here, the total, this is a per beneficiary per year spending. This is one measure that I've put together some round numbers, estimate of 2021 of a bit over $13,000 per beneficiary per year. And these numbers, by the way, are net of cost sharing. Hospital inpatient is a big piece of that, at over $4,000. Skilled nursing facility, another big piece, $800. Home health, a bit smaller. Hospital outpatient is almost up there with hospital inpatient. And then the biggest piece of all is physician at $4,400 per beneficiary per year. And I broke out as subsets what imaging is. For hospital outpatient, imaging is is $200 out of the 3,000 some. And it's about the same for the physician component of imaging. Again, $200 out of the $4,400 or so. So imaging itself is a relatively small piece of the whole budget as we look at the context. Now, suppose you're an organization you're an accountable care organization that's run by a hospital. What's your incentive for promoting screening, for promoting a shift to earlier stage? If you're in charge of this budget of $13,000, well, historically, what's happened for accountable care organizations is they have focused their efforts on the second line, the skilled nursing facility line, as the place where they can reduce spending the most. Because there's a lot of people in skilled nursing facilities that frankly do just fine going home with appropriate care, with home health and rehab from home. So historically, in the last several years, what we've seen is the hospitals have done anything but reduce their own revenue and spending. If they're at risk, they've gone after the skilled nursing facility. If you're an accountable care organization that's run by a physician group, or perhaps a private equity company that owns physician groups, you're going to go after the hospital inpatient piece, right? If to the extent you can cut spending to the hospital inpatient, that's a way of generating savings, and you get a share of that. So that's some of the dynamics that go on when we in what we call population health, is to look for targets, but the targets you look for depend on who you are and what your financial incentives are. So just a bit of background on that. And so back to the question, will thoracic health, will cancer downstaging appeal to population health organizations? A couple of things to keep in mind as next speakers go into detail, that downstaging probably reduces hospital revenue in the traditional model. Downstaging may reduce hospital profits even with shared savings. Surgery is very profitable. Money for quality can make finances favorable for downstaging. That is, it's not money paid to the providers, but it's money paid to a system for its outcomes. And what does all this mean for lung cancer screening, for thoracic health, for multi-cancer early detection, for things like promoting exercise? How does that fit into this population health model when the financial incentives are so strong to do things like reduce skilled nursing facility care, or to have physician organizations avoid hospitalization? And what technologies will be favored either under the traditional model or under population health over the next several years? So with that, I'm going to hand the virtual microphone over to Dr. Jaffrey.
I'm Jonathan Jaffrey. I'm a Chief Population Health Officer at UW Health in Madison, Wisconsin. I'm also the CEO and President of our accountable care organization, the UW Health ACO, and I'm a nephrologist in clinical practice. First of all, I want to thank you for having me as part of today's discussion. Screening and prevention are key parts of any population health model, so I'm thrilled to be part of today's panel. As Chief Population Health Officer at UW Health, which is the academic medical center affiliated with the University of Wisconsin in Madison, a big part of my job is leading the transformation of the healthcare system into one that moves away from the fee-for-service model of healthcare reimbursement, where providers get paid more to do more, regardless of outcomes and cost, to one focused on value-based care, where outcomes for the overall quality and cost for a population of patients is the focus. A big part of this idea is moving toward value, is identifying areas of waste within the healthcare system, as well as opportunities to intervene before people get sick. So as part of our movement to population health and value-based care, in 2013, UW Health joined the Medicare Shared Savings Program, which is a Medicare accountable care organization program, where healthcare providers voluntarily assume responsibility for the overall outcomes and total cost of care for a population of Medicare beneficiaries. In order to succeed under this model, we formed the Office of Population Health, which I lead. You can see our department logo on the screen now, and this depicts the three areas we manage. So number one is the ACO, which is a separate legal entity, a separate corporation that we created to manage all of our risk-based contracts, those contracts where we take accountability for the overall quality and cost of a care for a population of patients. This is the organization that contracts with CMS, the Center for Medicare and Medicaid Services, around the Medicare ACO. It's the organization that may contract and work with other payers in the area, as well as working with other entities in the community that deliver healthcare that perhaps we don't. For example, nursing homes and skilled nursing facilities, part of the care continuum that is not part of our own healthcare system. The second area is the population health care model, which is really how we are going to deliver on all this value-based care. So it's the development, the implementation, the oversight, and the evaluation of all those innovative clinical programs designed to succeed under these risk-based contracts. And the third area is community health improvement. And this is how we partner with other healthcare providers in the community, as well as community-based organizations and others that address the social determinants of health, things like housing, economic opportunity, that collectively we know have an even greater impact on health than medical care. So I'd like to take a few moments now to share an example of how under this program and these programs and the right incentives, we went about implementing some population-based screenings and did so quickly, effectively, and sustainably. So this slide is busy and clearly is print too small for you all to read, but it shows our performance during the first year in the program. Our first full year was in 2013. And so there are several dozen metrics. Without getting into the details of each one, we've got a performance there in a red, yellow, green matrix where green is good, dark green is better, and yellow is not so good, and red is quite bad. And so what you can appreciate even on the screen is that most of our performance was in green, with a lot in pretty dark green. But there were a few things that were in yellow with very poor performance or frankly, dismal performance in red. And these were some screening activities like screening for falls risk in the elderly, screening for depression, and screening for potential conflicts in medications through medication reconciliation. Now, the first year of performance, it was all pay for reporting only. So we weren't really at risk by having these poor scores of having some bad outcome, financial or otherwise. And so we took this opportunity to learn in that first year where our performance lagged and where we were doing okay and where we needed to focus for the next year. And so at this point, we're looking at 2014 performance and thinking about how are we going to make sure that we perform adequately there, because if in 2014, where it's now pay for performance, if we underperform, we've got some real financial dollars at risk, as well as the potential impact on patient care and public reporting that would be negative that we weren't interested in and excited about having go public. One of the challenges is that this information didn't come out until the middle of 2014. We didn't get this information until June or July of 2014, and the performance year 2014 at this point is already half over. So we knew we had to move quickly. And so while normally we might take years to roll out new interventions, we would pilot small tests of change and then evaluate the pilots and then tweak the model, roll it out in a couple more clinics, maybe a month later or the next quarter, and take really what could be years to roll out a new program. We knew that we had to go quicker. And so we really did it in a big bang model where we took several dozen clinic sites and implemented screening workflows really overnight. And so this is what happened. In July 4, you can see the first data point is June of 2014, where our performance is quite low, anywhere from in the 20th percentile to really no screening mechanism at all, performing at the very bottom. And then literally overnight in July of 2014, as we implemented these workflows, we got these metrics into the 70th percentile range, 80th, even 90th percentile range. And this was, again, across several dozen clinics. This wasn't just one or two small pilot areas. This was across our entire primary care enterprise. And what you can also see from this is that we track this with run charts on a monthly basis, and that performance was completely sustained. This gives you the first year of performance after implementation. We tracked this for several years on a monthly basis, and while you don't see the data here, it didn't budge. So this really was a fully scalable, at implementation, sustainable model, and our performance in 2014 reflected that. And so finally, here you see our rates of performance broken out by the MSSP population from the rest of the population. Because when we first did this, we were targeting just the Medicare beneficiaries, which represents maybe 10% of our primary care patients. And what you can see here is that the intervention, it's the intervention that really made the difference. There weren't some other practice changes that happened at that time. It really was the MSSP population where we were targeting the intervention and the screening that the metrics just took off. So while this may just be a small example of a change in how we approach screening for certain outcomes, I believe it demonstrates that given the right incentives and the payment models, even a large system like ours can implement broad changes. We can do them quickly, and we can sustain them over time. I'm looking forward to the panel discussion. Thank you.
Greetings. My name is Paul Lindbergh, and I serve as Chief Medical Officer for Screening at Exact Sciences. It's a pleasure to join this QIW panel to discuss innovative ways to leverage new technology to advance cancer screening. From an overall public health perspective, we all recognize that effective screening can reduce both cancer incidence and mortality, but remains underutilized in the United States. At present, national guidelines only recommend screening for a minority of target organ malignancies, with approximately 70% of all incident cancers having no standard of care screening tests. Unfortunately, detection of these cancers is often delayed until after symptom onset, when the disease process is relatively advanced and treatment options are both more limited and less effective. Late-stage diagnoses of unscreened cancers are more common in vulnerable populations, emphasizing the need for better screening solutions that enable equitable access for all populations. To frame the lung cancer challenge more specifically, we know this disease is the leading cause of cancer deaths for both men and women in this country, in part because most patients present with advanced stage disease at the time of diagnosis. And while approximately 15 million people meet criteria for low-dose CT screening, fewer than 6% of screen-eligible adults are adherent with existing guideline recommendations. Increasing participation in lung cancer screening will no doubt save lives, since early detection is associated with improved survival, as shown here by estimated 5-year survival rates of 60% on the far right for local, 33% in the middle for regional, and only 6% for distant metastatic disease. While advances in therapy will also contribute to reduced lung cancer mortality, our biggest opportunity to disrupt the status quo is through downstaging disease at the time of initial presentation, using novel technologies and population-level strategies to enhance both screening assay performance and patient engagement in lung cancer early detection. One way to expand the reach of lung cancer screening is to change the screening paradigm from single organ to multi-organ early detection. By considering cancer prevalence in aggregate, the number needed to screen, shown on the y-axis, shifts from impractical and cost prohibitive to clinically actionable and financially feasible. Applying this tumor agnostic approach would also afford the potential to screen detect less common malignancies, such as esophagus, pancreas cancer, others that currently fall outside of existing guideline recommendations. Encouragingly, the biology of carcinogenesis appears to be well aligned with the concept of multi-cancer early detection, since many of the key cellular pathways and promising candidate biomarkers are shared across organ sites. Recent progress in genetic sequencing, methylation profiling, proteomic analyses, fragmentation, pattern recognition, and other laboratory methodologies provides the potential to identify common signals from anatomically diverse cancers using a liquid biopsy approach. Further investigation is ongoing to determine which class, or more likely classes, of cancer-related targets will yield the highest performance characteristics in blood-based assays, with the general consensus that a scalable multi-cancer early detection assay will need to be optimized for high specificity to reduce the number of false positive test results that may lead to additional diagnostic evaluation, excess resource utilization, and heightened patient anxiety. Shown on this slide is the draft workflow for CancerSeek, a multi-cancer early detection assay that's under development at Exact Sciences. Discussion of multi-cancer early detection screening eligibility is envisioned during any non-urgent primary care visit, with subsequent blood sample collection and biomarker analyses. For the projected 99% of patients who test negative, repeat screening would be recommended at an interval to be determined. Conversely, for the 1% of patients who test positive, follow-up evaluation with PET-CT imaging would be recommended to identify and localize any of the targeted cancers. This model was recently assessed in a large prospective study conducted within the Geisinger Health System patient population. The goals of the study were to detect cancers not found by standard of care in the real world, to pilot blood test and workflow in a large clinical population, and to manage patient care by delivering test results. With respect to the study design of DETECT-A, the blood test used was a prototype of CancerSeek. There was a quality standards board made up of multidisciplinary experts who reviewed the test results. And then for those who were deemed to need a positive follow-up, there was imaging that was recommended and performed, and then appropriate follow-up after imaging based on those results. With respect to the enrollment, over 10,000 women were enrolled onto DETECT-A between the ages of 65 and 75 years over about a 2-year time period. And the only exclusion criterion was that they could not have had a prior history of cancer. Over a 1-year follow-up period, 96 women in the study were diagnosed with incident cancer, including 24 cases diagnosed by standard of care screening, 26 cases detected first by the CancerSeek assay, and 46 cases diagnosed as a result of symptom-based evaluation. Summarizing these data, the DETECT-A study found that application of a multi-cancer early detection test resulted in a 2-fold increase in screen-detected cancers, while further demonstrating the feasibility and safety of this novel screening approach. With respect to lung cancer diagnoses, CancerSeek led to detection of 9 women with lung cancer, which was 3 times the number of lung cancer cases detected by standard of care screening methods. Moreover, 7 of these women did not meet established high-risk screening criteria for lung cancer screening and would likely have remained undiagnosed until after symptoms appeared. The other 2 women whose lung cancers were detected by multi-cancer screening approach did qualify as high risk, but were not adherent with current lung cancer screening recommendations. Building on the promising proof of concept and early feasibility data for CancerSeek, the next steps in assay development for this particular approach will include initiation of an FDA registration trial and launch of a laboratory developed test, which are planned in 2022, to expedite clinical access while simultaneously generating additional evidence based on real-world experience. With the projected availability of the CancerSeek assay and other multi-cancer early detection tests on the near-term horizon, This novel strategy holds promise for shifting clinical practice to a much higher proportion of screen-detected cancers and reducing the overall and lung cancer-specific public health burden by expanding the screening target population with the promise for equitable access, increasing participation rates, identifying other currently unscreened target organ cancers that can be diagnosed at earlier stages, thereby reducing treatment costs and improving clinical outcomes. In order to achieve this vision, collaboration will be essential to both realize and accelerate that full potential of multi-cancer early detection. And it has to include policy, patient advocacy, academic, other key stakeholder organizations across the cancer spectrum. Appreciate the opportunity to engage with this group today and to continue the conversation. Thank you.
Well, thank you very much, Jonathan. Thank you very much, Paul. And I've got a question for both of you. And I was really struck by the University of Wisconsin ACO table that you showed, Jonathan, and the list of metrics that you manage the population with. And so the question I have is probably lung cancer screening wasn't in there, and probably multi-cancer early detection wasn't in there either. Didn't exist probably in 2013. But the question kind of for both of you would be, what do you think it would take to have either of those or both of them as a quality metric that someone who's in charge of population health management would watch?
Well, I'll jump in there. Thanks for the question, and Paul, it was great to hear that presentation. It's really fascinating and exciting because I think some of this multi-cancer screening does offer maybe some better opportunities, as you mentioned, to do something in a way that starts to have a more cost-effective approach for some of these population health programs. And I should mention, it's also great because I feel like we got a good Madison representation here. Exact Science is based in Madison. So those metrics, so you're right, there weren't, lung cancer is not on them, and multi-cancer screening certainly isn't. And, essentially, I think we running ACOs kind of respond to a couple different incentives here. The most obvious is the total cost of care that you talked about before, and driving that down, because that's how we get those shared savings. And then the outcomes are measured in different ways. But the big way is it's measured by this overall quality score that's a composite of these various metrics that do change as the years go on. Sometimes some of them top out and we move into other ones. I think heard a little bit about that in the earlier session about how NCQA does that and tries to do that. But so, those quality metrics aren't necessarily things that we would, who run the programs or clinical leaders would necessarily say, yeah, these are really the key things that point to quality outcomes. But at the end of the day, we do respond to them. And so, my example was a perfect example of that. We saw these things that I wouldn't have said that those metrics weren't important before, but they didn't rise to the level of us implementing workflows until we were judged on them. And so from a policymaker perspective, there's some, I think there's some ways that they think about looking at those metrics, and when they top out, moving in different ones, and how we get to a prioritization of that is, there's a little bit of sausage making there in terms of who advocates strongly and best for things, and how they, how they make it onto somebody's list of measures. I will tell you, I remember back 10 years ago when the ACO rule first came out, and I was actually working at the time for the Senate Finance Committee, and the ACO rule just got proposed, the original. This is in 2011. And the original number of quality metrics was 60 something, 65, I think, about double what it ended up being. And so, as you might imagine, we heard from a lot of different constituents about that being, about this topic. Most stakeholders said, well, that's way too much. You can't suddenly dump another 65 new metrics on us. But not everybody. There were people out there who said you need more because we need to follow more things. And so I guess to just sum up to the question, I think that for these kinds of things, the incentives that the ACOs follow will be more about the quality reporting, unless we can really emphasize and show how screening can, in a single year, reduce costs, because it's not likely to in a big way. But I think the multi-cancer approach is a huge opportunity, and it gets actually beyond some of the kind of the infighting, because this is a discussion about lung cancer screening. There's probably somewhere right now some group is talking about pancreatic cancer screening, and so on and so on. So that was a little bit long-winded, but I'll stop there.
Yeah, Jonathan, I don't have a lot to add to that other than Bruce, thanks for setting the stage. And Jonathan, it's been great to watch how our organizations are continuing to collaborate. And I really do like the strong Madison connection. But, the way I would frame it is more maybe from a clinician's viewpoint than an economic standpoint. But we know that more people getting screened can lead to better health outcomes. We can talk about overdiagnosis and some of those sorts of things that may apply here as well. But if you frame it around lung cancer, there are patients who are eligible for screening who aren't getting screened. In order for us to have that impact on mortality, we need to get more people screened so we can find cancers earlier and really intervene more effectively. I think that is a addressable challenge, and there are multiple ways to get there. If we do this by screening for other cancers on top of lung cancer, and we have the perspective that multi-cancer early detection complements standard of care screening, then I think these other questions can be addressed through additional study, through modeling, et cetera. But at the end of the day, we have technology, we have an opportunity through more widespread utilization of the tools that are currently available or are in later stages of development to really have a clinical impact to find patients who currently are developing cancers when we don't have anything effective to offer. And that's the paradigm that we need to shift. And then we can figure out, not being overly simplistic, but we can figure out how all of that fits together under a financially feasible paradigm.
Dr. Lindberg, we had a couple of questions for you. One came from an attendee in the audience. In your study 9 women were diagnosed with lung cancer. Can you precise the cancer stage for them? And I'm going to tag on to that. There was also another question from one of our prior panelists regarding liquid biopsy studies are showing that sensitivity in early stage lung cancer is very low. And can you comment on the sensitivity of the Exact Sciences test in those 9 cases of lung cancer, as well as other cancers?
Yeah, I don't have the numbers immediately available. I can tell you that over half of the lung cancers were diagnosed at earlier stage. So that was one of the goals. It wasn't a primary endpoint of the DETECT-A study, but there was a shift towards earlier stage diagnosis compared to existing standards or existing distribution of stage at presenting diagnosis outside of the study. The sensitivity for the CancerSeq assay, this was a prototype version that included DNA markers based off of circulating cell-free DNA combined with some protein markers. The sensitivity was not high. It was somewhere in the 30 to 40% range, depending on how you define sensitivity and your denominator, et cetera. But that's not the goal of this test. This is a test to complement standard of care screening. So in essence, any cancer that's detected on top of standard of care is a cancer that would not have been diagnosed until symptoms developed or clinical evaluation detected that disease. So I think that as we continue to evolve the technology, the sensitivity will continue to improve by combining multiple classes of markers. I think that is definitely achievable. But the key performance metric that Exact Sciences, other groups are targeting is specificity, so that we have fewer false positive cases, we don't cause anxiety, unnecessary follow-up, et cetera.
And this also is to you, Dr. Lindberg. Dr. Yankelevitz, please jump in if I don't get your question right. But he was asking if how you all get a test approved for cancer screening without an RCT, and why is it different for a blood marker than other imaging markers?
Yeah, it's a great question. And we have been involved, and we've actually convened stakeholder summits. Prevent Cancer Foundation has been a key player in those conversations. Because some of the standards need to be changed or modified. If you think about how would we do a prospective trial with multiple cancer endpoints, it's really hard to think through even the simple questions like the study design, the performance estimates, the event rates, the weighting of different cancers across organ sites, et cetera, et cetera. So it becomes complicated really quickly. Now, that doesn't mean we shouldn't do it. And at Exact Sciences, we are talking about additional prospective studies. The DETECT-A study was 10,000 women. We are right now actively developing, or at least discussing, trials that would be substantially larger than that. I know other groups are doing the same thing. But we need to come together to agree on what are those evidentiary standards that are required for regulatory agencies, for guideline bodies, for payer groups, et cetera. And I hope that we can think a little bit outside of the current guardrails, because I don't think we can get there quickly enough if we stick to the same standards or pathways that we have traditionally followed in terms of trying to bring something that's as innovative and potentially paradigm disrupting as a multi-cancer early detection assay.
So Anita, I would like to add a comment, if that's okay.
Absolutely.
Thank you for the talk, by the way. I did raise that question only, and it's not because I'm advocating that there be a big RCT done for this, because I appreciate the challenges that you were describing. And I don't advocate for RCTs and screening to begin with, but it was something that was really insisted on for imaging. It's really been insisted on, but what I see your test is I still see it as a screening test. You can describe it as you're risk stratifying and then getting the other screening, but to me it's just another screening test on top of other screening tests. You're screening for who should be screened by the other test. And so I think, and I have no problem with it. I think the idea is wonderful. I'm assuming these blood tests are going to get better and better. That's the only direction they're going to go. But I worry that, how you're going to get through all the regulatory, how you're going to avoid the naysayers saying, oh, you got to randomize and you got to show a mortality benefit, that sort of thing. Because ultimately, I don't see this as different than what happened in imaging. And if you can get by without doing that, it'll be interesting why it was so insisted on in imaging, and whether future imaging tests can use that same paradigm that you'll be using.
It's a great comment, and it has been a topic of frequent conversation. So I don't have the answers yet. When we convened our first stakeholder summit just over a year and a half ago, we asked the thought leaders to come up with the key questions, not the answers, because I don't know that anybody has the answers just yet. Do we need a cancer mortality endpoint? Do we need a cancer incidence endpoint? Could we look at downstaging as an endpoint? Again, how do you combine the data across organ sites? So these are questions that I think inherently don't lend themselves in a very easily addressable way to the development paths that have been traditionally followed with imaging and others. I will say, though, that Exact Sciences, and I know from talking with some of the other groups that are actively involved in this space, there is no desire to take a shortcut around evidence generation. We need to make sure that what we would bring to clinical practice truly has demonstrated value and that, what would be the result of a multi-cancer early detection strategy is better than what we have today. So still more details to figure out. In my opinion, what we can't do is wait for the technology to be available and then try to figure all this out. I think we need to be working on these very important questions as key challenges right now, hopefully doing it collaboratively with all of the groups that I mentioned in the video presentation. I'm confident that we can find a better way forward. And maybe the first pass won't be the final pass, but hopefully we'll continue to make progress as quickly as possible.
So just a final comment. I agree with your approach. I think that going down the path that you're doing is excellent. And I think the way you're going to approach evidence is excellent. I guess what I was pointing out was that many of the people that are now advocating this approach, I'm kind of pointing out the hypocrisy that there was when it came to CT screening. Those very same people that are now advocating this approach were saying about CT screening, only a randomized trial is the only evidence that counts. That's it. Nothing else matters. And now I'm seeing a major shift when it comes to blood tests for saying, let's use a different approach because the technology is so wonderful and that we need to move faster. And I agree with that. I think that is the right approach. But it held back lung cancer screening by not doing that for 20 years. So anyway, that's my comment.
Well, thank you, David. Anita, do we have?
We have a couple of other comments from our prior panelists, Dr. Mulshine, and then also Dr. Pasquinelli, and I'll call upon Dr. Pasquinelli first. She had a question on downstream costs.
Yes, so my screen is frozen, but you can see me? Okay. So I have been looking at using a multi-cancer screening test with our lung cancer screening population, and we serve mainly minority population, heavy smoking histories on the south side of Chicago. But as I'm looking at this, it seems like the more sensitive the test is in the smoking related cancers, which is good to connect with the screening test. And my thought though is, it seems like for every one cancer detected, there is another case that they have a cancer signal, but we can't figure out where the cancer is. And then if we have to do a lot of extra testing for a positive test, such as a PET or other MRIs, or depending on where that cancer, they think that the origin of that cancer is going to be a lot of cost to the patient or to the insurance company. And I'm concerned about them not being approved for this. And then it becomes another disparity within the cancer screening population. So my question is about the downstream cost to the patient for a positive screen, and also how accurate to understand exactly where that cancer is coming from.
And Mary, thank you very much. I'm hoping that both Paul and Jonathan can answer that. I know you directed it at Paul, but I feel an urge to get back to the population health topic of the session.
Maybe I can just give a little bit of context and then turn it to Jonathan. So great points, Barry. In the DETECT-A study, which again, based on 10,000 women, men weren't included in that study for a variety of reasons. The positive rate was 1%. So going on to a diagnostic evaluation with PET-CT was 1% out of in the 10,000 women population. Of those, the number that had a positive blood test result and a negative PET scan, and their follow-up only required the PET scan in the majority of cases to get to a conclusive positive or negative. There were about 38, I think is the right number, participants who did not have an answer after the PET CT scan, either positive or negative answer, and went on to additional follow-up. There was only a handful of actually incidental findings. Some of them were considered false positives, but there were findings like colon polyps with high-grade dysplasia, which have clinical significance, but did not meet criteria for a true positive test result in the DETECT-A study design. So at least based on this initial experience, the rate of follow-up evaluation and number of tests needed for that follow-up evaluation were relatively small.
So maybe I'll jump in and talk about this from a very, very different angle. And to Bruce's point, sort of bring this back to kind of the incentives and population health and some of the things we're trying to change. So, I mean, it's a very important question, I think, because it really does show that it's not always that things that drive better patient outcomes or better population outcomes and improved quality also lowers costs, right? Sometimes it raises costs. There are areas we find that do lower total cost of care that are better for patients. Bruce mentioned nursing homes. There are a lot of people who do fine at home. In fact, they do better, and that's what they prefer, and it's cheaper. Well, that's a pretty straightforward win-win, and we don't have to really argue about it. There's also ways to avoid hospitalizations, so-called ambulatory care sensitive conditions, where if we beef up ambulatory care, particularly primary care, we can avoid hospitalizations. That's good for patients, right? Those are better outcomes, and it's cheaper. But then there's a whole bunch of things that where that's not true, where costs might go up in order to get better outcomes. And importantly, the better outcomes, or even the savings, there may be savings, but they may take more than a year or 2 years or 3 years. And that becomes very difficult in programs where you're caring for somebody and the performance year is in fact a 12-month period. And also, in fact, people may shift under your care from one performance year to another and over time. But so I do think it's noteworthy to think about, to me, so this is a little bit more kind of, I guess, philosophical and even philosophical, even maybe a little existential. This to me is why models like accountable care organizations are so important, because they really are provider driven. Now there still are some conflicting incentives that come up. Bruce alluded to, hospitals versus physician runs. There's some evidence that physician run organizations, ACOs, may do a little bit better, with the theory being that they don't have the same conflict of incentive of around decreased hospital financial incentives around decreased hospital stays. There's also some evidence that the hospital-led ACOs decrease physician payments, but not hospital payments, and physician-led ACOs do just the opposite. But so, and all that said, I believe that there's something about providers driving these that are a little bit different than the health plan that's a little bit more removed. And not that there aren't health plans. I mean, the health plans are there to improve the health of their members, but it's a little bit different than, I think, those of us who also still have to sit in front of across the exam room from patients on a, if not daily, then at least weekly basis. And so it's hard to it's hard to get to see how some of the overarching incentives don't end up conflicting with some of these things that don't have a relatively quick payoff. But that sort of goes back to sometimes thinking about how do we drive the incentives. Maybe they're not just the financial incentives, but drive those incentives by having a specific quality metric in there. So if we do get to the point where there's a really well accepted multi-cancer screening tool, that again becomes maybe a reasonable candidate for a metric for ACOs or for Medicare Advantage or for health plans. But it's hard to get that balance. And I think at the end of the day, one of the things I like to point out to people is, because one of the models on the ACO is that there's in order to keep getting shared savings, you have to keep lowering costs. Once you've got that, Bruce mentioned there's a benchmark. Once you achieve that benchmark, after a few years, your benchmark gets lower again. It just ratchets down, as we say. And so what I'd like to point out is that while the quality aspect of things we're always shooting for higher and higher quality. We're not always shooting for lower and lower cost. The goal here is not to spend nothing on people's healthcare. And so we don't know what that right number is exactly, but we are going to have to spend something. And I think we do want to accept that.
Bruce, I don't know that we're going to have enough time to address Dr. Mulshine's question or Rick Avalon's.
Well, I think we do need to make time for our chair to
Okay.
have some closing
invite
comments.
him to this discussion then, Jim. I will start with his question. Maybe he had to step away. He had asked from a cost of care perspective, for $300, you can save a thoracic CT scan, which can be used for lung cancer detection. Then you can read the scan for COPD and coronary calcium and then osteoporosis. How can you get a better value than that?
You can make it 150.
There he is.
Yeah, so Anita, that's the question. The opportunity here with the radiomic approach to thoracic CT in the context of 3 of the 4 leading causes of premature death in our society is profound. And from an ACO perspective, if you can profile this in your covered population, there's a whole array of preventive and other measures that have been, advocated by various cardiology specialist society recommendations at this point in time, that now U.S. Preventive Services Task Force has done for lung cancer, and that in this meeting we're talking about extending to COPD, along with lifestyle, physical activity, and other lifestyle features that could be modified. From an ACO perspective, how is that not something that is urgently actionable?
Well, I think I guess the problem comes down to maybe 3 things, and a problem's not the right word, but so the first one is we've talked about a little bit, which is when you're talking about it as a value, as a cost perspective thing, cost effectiveness, what's the payoff? Is the payoff in 12 months? Because that's kind of how ACOs are pushed to judge their total cost of care. So that's one thing. The second is kind of a bandwidth thing, I guess. So there's only so many things that people can do in terms of setting up workflows. And I would say that ACOs are still relatively young in doing things like addressing, building that advanced primary care model, addressing ambulatory care sensitive conditions and post-acute care and things like that, and managing the 30-some metrics that are put out in front of us. And then I guess one final thought is, as you were speaking and describing this, I'm not sure even an ACO is necessarily the only target here. I mean, I just think if you just think about a health system, couldn't you ask the same question? Really, I mean, how if you can identify in one fell swoop 3 or 4 causes of common causes of premature death, there's actually fewer incentive issues outside the ACO. I mean, if you just think about it in a fee for service model, where you don't have to worry about whether that $300 pays off, because of course the provider system ordering that stuff isn't paying the $300 in that situation. So I guess I wonder how you can get that sort of entire paradigm of here's an imaging test that you can use for it already is built in multi-screening modality. In this case, not multi-cancer screening, but multi-disease screening.
I'm going to ask the chair if we have one more question that just came in. Do we have time for a question on PET versus CT?
That's a pretty quick one, and then we can get a break.
I think Rick, the chair, has said you can ask your question.
Well, I think it may have been answered already, but the basic issue here is that if you're going to use PET CT as your final check, you're going to miss a lot of small early cancers. because PET resolution is nowhere near what CT or, well, what CT provides. So one thought was, is there a way to use PET in certain situations when you have, let's say, a liquid biopsy result that maybe screams that there's a lot of cancer present. And when you have, let's say, a more trace amount, switch over to CT. Just a thought.
Great thought, and I don't think the final answer has been defined yet. The PET-CT seemed to be the best option for the DETECT-A study, but actively discussing if that's the approach that should or could be used most effectively moving forward.
Well, I want to thank our panelists who've had a really lively discussion, which reflects the energy and insight that you guys brought. So thank you very much. And with that, we have a short break before our next session, which starts at, sorry, shuffling the papers here, at 2:30. So we'll see you all back at 2:30. That's the Transforming Thoracic Health for Everyone. What does the field need and what do people need? And a reminder that there's a form for folks to fill out on how much you liked it. And if I win the competition, I get an extra dessert tonight. So I want to make sure people fill that out. Thank you.